Okay, so welcome everybody to our journal club. As you see, we're going to go through the movement disorder journal that was up in December last year. So I hope everybody have a good Christmas and vacation. And I was in Colombia and visiting my mother. Unfortunately, she has an accident, but I was a joy to see her anyway. So let's start with the journal club. So again, this is um, the movement disorder journal. As you see, this is something you guys are very familiar with. Houston, we have not a problem, but AI problem. It's for the artificial intelligence. So artificial intelligence is something that everybody probably is familiar in all the fields, and we apply in medicine, especially we talk a little bit in Parkinson's disease. So they actually did a good review in this journal, several studies, and see how we can apply artificial intelligence. And now we are relate more and more in computers. So you go to fiction, actually, you see movies that probably the computers take over from governments and take the power. So it seems now we're getting there, but it seems the computers have been changing the way we do. You see, actually, we use computers for do surgeries. So using computer, the Da Vinci, now you have laparoscopic. So that's very precise. But you see, there is a series and TV and Netflix is called The Resident. It actually seemed very interesting. Actually, I found a mistake. They found they placed in a CT scan of the head, said the MRI. That was not an MRI, it was a CT scan. But it's a very good. It's very interesting. It's very dramatic, but it's very human. It's very nice. You can entertain with that. It's very important. And actually in that you're going to see one immigrant. Thank you for having immigrant doctors here in this country. There is a Nigerian physician that actually she does surgery by the Da Vinci. She's very good. So yeah, I just want to look for how the robots. You see how the robotic surgery, especially in prostate cancer, in gallbladder, it had been changing the way to do surgery in many ways. Very precise. They even had the issue talking about tremors or something. Robots are more precise. So basically, they're looking in this article how the artificial intelligence can help with the diagnosis of Parkinson's or Parkinsonism or other conditions similar to that. And now with the computer, with this artificial intelligence, we can place different things together, like the genetics, the imaging, the clinic, and finally we can make some diagnosis. And if we can more or faster diagnosis, we can go a better prognosis, and we can do intervention because sometimes, very often, again, you as human beings, we haven't make an impression. For example, I have one case that I had an impression that there was an issue with probably normal aging process, but then I lost the patient, and 3 years later, I said, no, but you said it's an aging process, and then they got an MRI, and then the patient was diagnosed with normal pressure hydrocephalus. So we need to get the follow-up, and then hopefully we can have all the tools to make diagnosis and avoid misdiagnosis. So that's the thing. But this is what we talk about, the artificial intelligence and Parkinson's disease. I'm not going to go all the details, but what they want to bring this attention is a tool that we have now, and there is many studies. And in this review, they mentioned that it's good, but it seems there's a lot of research to follow. But this is the future, amazing. More and more computers and helping us to make the diagnosis or intervene. Later in this talk, we're going to talk about deep brain stimulation and how this artificial intelligence is helping. In the past, we placed the electrodes, and actually Dr. BBS and I do the programming. And the first programming for DBS takes for us very long time. But now with artificial intelligence probably the computer can do all the programming by itself. So we are going to be kicked out from computers, possible. It's a very good, helpful tool, yes, definitely. We're very excited, but at the same point, we see how valid, and that's where the research is have been taken with us. So the artificial intelligence has been used especially with neuroimaging. So we had to look for DAT scan, specs, and all together with the clinical, the way, because in our eye, we can say, okay, when you see the DAT scan, we see the shape of the coma, say, okay, I see that, but the computer actually can place different patterns for different conditions. And the artificial intelligence, now we cannot say we cannot distinguish Parkinson's with Parkinsonism or dopamine deficiency with DAT scan, but it's possible the computer can do that. And together with alpha-synuclein, we have been talking with some patients this morning about getting a skin biopsy for alpha-synuclein. And then actually with the biopsy, you can look if, when that's a part of the articles here in this journal, it is present in the skin, it's present in what part of the brain. And that way, in different places, alpha-synuclein, we can make a different diagnosis. Or looking in the biopsy, different is only in the oligodendrocytes or is another part of the glia. There could be a big difference. And again, going just in general, you have somebody with alpha-synuclein affecting the real Parkinson's that will be affecting the Lewy bodies inside the neuron. So that the Parkinson's, and that usually can decrease the dopamine, and you give somebody dopamine in that particular person, dopamine works. In the Parkinsonism, the alpha-synuclein be affecting the glia, meaning the cells that support the neuron, and the neuron by itself has no problem. So that means the neuron by itself have plenty of dopamine. And these people that look like Parkinson's or Parkinsonism, we give dopamine and the dopamine doesn't work. I will give the example that Parkinsonism or Parkinson-like syndrome is similar like in this country, somebody like me, people are thinking you are from Mexico. I say, no, I know Mexican, I'm Colombian, right? It's very difficult to be Mexican, to be Colombian, or to be Latino, be Parkinson or Parkinsonism. So on the spectrum of Parkinsonism could be many things. Could be from multisystem atrophy. Multisystem atrophy could be type C or type P, or could be corticobasal degeneration, or could be Lewy body dementia, or many other things. So that's hopefully in the future with this artificial intelligence, we can help us place the clinical, place the genetic, place the imaging, and then go tell, no, doctor, you're dealing with this before we go to the diagnosis. Because otherwise you go one place to another, you have to go to a sub specialist for MSA or people in other places and sometimes we don't get the clear diagnosis. Okay, so I, in Spanish, I, that means there. Artificial intelligence is something that is going to come soon to all the fields in medicine. And look at this. So basically in this table, they tell us they can do the classification of the Parkinson's versus a healthy control. This is the first part right here in the top of this. So we will see that could be what is normal, what is not. They can probably differentiate between Parkinson's versus atypical Parkinsonism syndromes. And they can hopefully get a near narrow when you get to one or the other, identify the different Parkinson's disease subtypes. So Parkinson's disease is not only one condition. You see some people have tremors, some people have no tremors. We call the tremor type versus the akinetic type. So there are different presentations. This we call the phenotypes. And then we can look about the staging. Now we have a score clinically, but with PET scan, usually we do only that scan, but we get all this artificial intelligence can tell us what the stage of Parkinson's, how much the dopamine has been decreased, or how much have been advanced with clinical, but as well with the histopathology. So we're getting more there in Parkinson's. So basically, before we said Parkinson's disease is a clinical diagnosis, but not anymore. Medicine have been changed at the point that in the past we say, I'm sorry, another example, another beta, another abnormal protein in Alzheimer's. They usually said, no, I'm sorry, you have Alzheimer's. We cannot do anything for you. But that has been changed, and now we just mentioned over and over. We're very proud to have the Memory Clinic and Intercoastal Medical Group, and we're doing now testing. We have the beta amyloid PET scan, and even people thinking that are okay. We in the past say, no, you have mild cognitive impairment. Again, back in the day, say, no, it's aging process. Now there's a question, we can test you. We can test you for Alzheimer's. Even your test is a little off. You say, no, it's my memory. But you have the protein, the beta amyloid, which show in the PET scan, and we can treat you early in the game. Like we had somebody yesterday. They were surprised, and we started treatment. So we have two medications Hopefully, can say the same for Parkinson's soon. For Alzheimer's, one is called Kisunla, and the other one is called Leqembi. There are infusions, and we have it in the same clinic. So with this artificial intelligence, we look for the alpha-synuclein. We can typify what type of Parkinson's or Parkinsonism, or you have it or not. Remember, there are a lot of things that can look like Parkinson's. That could be like normal pressure hydrocephalus. Normal pressure hydrocephalus can make you walk like a little magnetic gait. That could be confused with shuffling gait. Okay. So another thing that this artificial intelligence with all the tools can look for conversion for Parkinson's disease and look for another thing. Sometimes it's very difficult to say this is MSA, or you start with Parkinson's and now you have autonomic dysfunction. We said this is MSA or it's Parkinson's plus. In the past, the Parkinson's plus we call the child-Drager syndrome. Now it's called Parkinson's plus orthostatic hypotension. It's very common now with the progression in Parkinson's, people start having dizziness and having orthostatic hypotension. That doesn't mean that you necessarily have to have MSA. It just the difference between MSA and Parkinson's plus is the carbidopa is working. I already just mentioned the alpha-synuclein is inside a neuron, so I give you dopamine is working. Now the problem you have to another problem, which is, again, Houston will have a problem. So the problem now is that we have orthostatic hypotension, but it's still the carbidopa is working. So that's the difference. If you were having MSA from the beginning or something like that, carbidopa doesn't work. So when they have a question about if the carbidopa is not working, is why we can do the dopamine challenge. In that way, we see in my eye, because every patient said, no, I stop it and see I go back, and probably it's working, but then I'm looking at my dopamine challenge, do the score, there is no improvement, but side effects, then we say probably it's more MSA clinically, right? But then we had the skin biopsy, they had the DAT scan or the SPECT to look at that. As well, again, remember this is not only, Parkinson's is not only tremors. We talk about cognition, we talk about anxiety, we talk about sleep. So placing all things together, we can make a more accurate diagnosis. And then we go to the drug therapy. Remember, not only how effective is the medication of Parkinson's, but some medications can induce something similar to Parkinson's. It's a drug-induced Parkinson's. Like somebody have a problem with depression, now people use like something like Abilify or something like that, or Ciprexa, which is too bad, they can induce Parkinson's, drug-induced Parkinson's. And then we talk about deep brain stimulation. And then we want to talk later on in this discussion about deep brain stimulation, what we think about movement. But deep brain stimulation has been used as well for depression, for obsessive compulsive behavior. And in one article we want to show you later, we see the nucleus of Megener, which is the area for the memory with acetylcholine. We're thinking that probably in the future we can do deep brain stimulation for that to improve cognition in Parkinson's. Okay, so that's the same thing. So we have been reviewing several studies to look how this new technology can help in Parkinson's for the different things that we just discussed. So let's move to a different topic. So far everybody's waking up. Is there everybody good? Okay. You had lunch? I'm glad you had lunch. Okay, so now genetic counseling. So somebody asked me this morning, do we have to do testing for Parkinson's? So I mentioned to you in the past, what is true today probably is not in the future. Usually we say the Parkinson's is, for the most part, idiopathic. 85%, we know we don't have a reason. And I always explain to you the meaning of idiopathic in medicine. That means we are idiots. We don't know. For most of the 85%, there is no reason to have Parkinson's. But if you have or have been in the military, that I have many, and I appreciate the people from the veterans, and I'm retired military by myself, a retired lieutenant myself. I appreciate your service. So many people being in the military have been exposed to the Agent Orange, or people in Camp Lejeune have been exposed to toxins, or here in Florida, many people have been exposed to pesticides. So all these can produce Parkinson's. When all these pesticides or toxins, the Agent Orange, or anything that can affect the mitochondria is the organelle in the cell that produces energy. So I will give this an example you are like you remember what happened in Russia and Chernobyl when there was a nuclear pump. It's good to have nuclear to have energy, but there's something going wrong, big disaster. The same with the mitochondria, which is the organelle to produce energy. So we damage the CoQ10, which in that is the paraquat, the can produce damage. Then you can get Parkinson's. So that's so important. So now there is some variants that we find more frequent with Parkinson's disease, which is the GBA1 variants. So we are getting a little more focus in the genetic because this is very common variant in the genetic. So the GBA1 or glucocerebrosidase, you can repeat that for me, please? Glucocerebrosidase. You see, you cannot complain about my accent now. So the GBI1 or glucocerebrosidase is very important and very common known genetic risk for Parkinson's disease. So in the studies and research is going to more to that pathway because again, most of the time is idiopathic, but you have many members of your family with Parkinson's. We're looking about mutation. You are Jewish with for the RK2, but this new focus is this abnormality or genotyping that can be across the world. We find that has been in different countries. It's not only one country. Again, and it has been, we are focusing a little more in the genetic. So many people saying we're getting a more interest in the genetic. Genetic testing in Parkinson's was very focused in the past. And again, what is true in the present could be not true in the future. Usually, young onset of Parkinson's, you are 40 or 50 and you get Parkinson's even earlier. I have somebody like 20, 28, the youngest with Parkinson's. In those people, we wonder more genetic. So usually when it's a young onset Parkinson's, you're looking more for genes and what's going on in the family. So usually that. But you presented 60 or even 80 late onset, that means you have been doing exercise, late onset Parkinson's, most likely genetic is not playing a role, but you'd be surprised. Probably, when we said probably we can do something more in research or we find something different. So I just want to place the book, the GA1. So Houston, we have a problem again, A1, again. Artificial intelligence and GBA for that, glucocerebrosidase, so producing this Parkinson. So conclusion. So we have now neurogenetics involved in Parkinson's to make the diagnosis. And there is an increased interest to look for genetics and look, because initially we really said, no, it's not, but now this is an eye-opening in our diagnosis. So we will have more comprehensive. We talk neuroimaging, we talk neuropathology, we talk biopsies, now we talk about genetics. Okay, let's move forward. We will keep in our journal. So the acetylcholine is very important for memory. And again, talking about Parkinson's most of the time, we forget about cognition. So in some point, if the caregiver or yourself are thinking the memory is not as good, we had to try to think about cognitive testing. We're thinking, oh, this is aging process, but remember having Parkinson's, you're more in risk to have Parkinson's associated dementia. And sometimes it's not only Parkinson's associated dementia, could be as well Alzheimer's. Sometimes in some articles, we look at it not only the acetylcholine being decreased in Parkinson's, but as well, unfortunately, some people, because in your age, on our age, it's in my age, but now, remember the beta amyloid can be accumulated for 15 years. The future of getting the treatment for Alzheimer's is test normal individuals with the cognition. It will be a blood test, and then you'll be positive for beta amyloid. You start treating before even have any problem with memory. So you have the waste in there, you take it away, and bang, you probably cure. So that's the future for that. So the acetylcholine is very important for memory. So that's why we're talking about medications for Parkinson, like Artane, or other medication that is good for Parkinson, but is not good for cognition, or medication for your bladder can affect your memory. So be aware of that, okay? So we see that we're looking for the acetylcholine, and again, I mentioned to you, it's possible the center of major nerve, which is in the frontal lobe, could be probably a target in the future for the brain stimulation to improve cognition. So let's talk a little more about this. So in the abstract, they tell us the different types of acetylcholine cells. And in one point, I want to show you as well MRIs and how they localize these cells. So look at this. It's a beautiful picture there in this journal. So you can look in color those small centers for you have the acetylcholine, and actually getting better and better with neuroimaging to localize those areas for the memory. So the nucleus basalis of Megener, it could be probably in the future a target for deep brain stimulation. Again, in the next slide, I want to show you how in the different stages, what is normal, what is not. In the first one, in the left side, you see what is somebody with normal amount of acetylcholine cells. And then when they start declining, you see that in orange. And finally, in red, when the cells acetylcholine has been very decreased in the brains with somebody with Parkinson's, then you start having dementia. So that has been TP5. And we can look at in the MRIs, and actually the high, Tesla is not only the electric car. Tesla is you qualify how strong is an MRI. And usually we use a Tesla 3 and something in a regular center. But in places in research, they have a Tesla 10. And actually we can make diagnosis with Parkinson with those Tesla, not with the Tesla we have here, looking for the substantia nigra. But here in this functional MRI, you can see for the areas of the memory, for the areas of the acetylcholine in different colors. So that's the functional. Okay, so it's very important to, in conclusion, look for the acetylcholine cells, looking for the cognitive impairment. We have to make you more aware that not only Parkinson's can produce the tremors, if the medication is not working, you have anxiety, but unfortunately, the acetylcholine cells or neurons have been decreasing in Parkinson's, and some point you can have impairment or you can go to dementia. So it's very important in some point, if I have some issues with memory, get a screening sooner than later. And again, it could be not only Parkinson's. It's possible in some point you have some phenotypes or some concern about Alzheimer's. Then we can test you for Alzheimer's now. We can do the beta amyloid PET scan, and could be, again, if you are positive, even though you have Parkinson's, then it is possible for beta amyloid. We can treat the beta amyloid now. Again, that's the cure for Alzheimer's? No, it's not the cure for Alzheimer's. The cure, again, I gave the example for the Leqembi or Kisunla, which, we're very excited about having this first time to have some, we scratch in the treatment of Alzheimer's. It's back in, I give you an example, it's back in the day, like AIDS, HIV. Initially, people were very, oh, you have HIV, not even touch it. No, we were very worried about it. And nowadays, we don't even talk about HIV. We had treatment. In the beginning, we had treatment, people not dying, and now we don't talk about what you love, zero. We're fine, good. The same with Alzheimer's. With this now, we just decrease the progression of Alzheimer's. We are not curing Alzheimer's now, and hopefully in the future we can say that, right? But if you are very functional and you just decline 1 point in 1 or 2 years instead to go downhill, it's excellent. We make you functional, you can pay checks, everything. So what we are, and that's why we're very excited. Okay. So talking about that, let's go and turn the page again to another article. So we're looking about biomarkers. So in Alzheimer's, the biomarker is beta amyloid. In Parkinson's, is alpha-synuclein. So looking about biomarkers, actually, we can make the diagnosis of Parkinson's sooner as well. You have the appendix out, or your saliva, or you have a question about having alpha-synuclein Parkinson's, something similar. Nowadays, we have biopsies. And again, hopefully, we can make more accurate diagnosis with the pathology. Where is the alpha-synuclein? If the alpha-synuclein is in all the cortex, we can make a diagnosis of Lewy body dementia. If the alpha-synuclein is only in the substantia nigra or something close, Parkinson's. If the alpha-synuclein go to beyond toward the brainstem only in the pons, for progressive multisystem atrophy type C, and so on. But again, you say, how are you going to do a biopsy that? No, that's what the skin biopsy and the artificial intelligence and the brain imaging will help us to make the piece together. And you see an MRI and somebody with multisystem atrophy type C, you see the cerebellum is smaller or the brainstem is smaller. I say, okay. Or you have somebody with PSP, progressive supranuclear palsy, and you see the midbrain is small. Okay, you see probably that's the diagnosis. But again, that's the artificial intelligence can help to place all the pieces together. So, so the alpha-synuclein is the biomarker for Parkinson's. So now we will have a tendency to change the name of Parkinson's, looking for the Lewy body pathologies. So the biomarker or the physiopathology for Parkinson's, back in the day, we do biopsy, so getting a brain, somebody died, we see in the brainstem the substantia nigra. Looking in the stem, we see the Lewy bodies, which is alpha-synuclein-like package, and it's okay, that was Parkinson's. But now we can do that in vivo. We can try to get the alpha-synuclein and see how extensive or what parts of your brain is affecting. So again, will be a target. The same we target the the beta amyloid. We can target the alpha-synuclein, and there is studies now for get the treatment with infusion to modify Parkinson's disease. Nowadays, we said the only thing that is neuroprotective is exercise, but hopefully in the future, we say, okay, you have positive alpha-synuclein, okay, go to our infusion center and let's the treatment. And in previous talk, I show you different articles for the New England Journal of Medicine that there is some studies already going on in that regard. Okay, so look at this. What's the localization? So you have the CSF. Actually, you can see a biomarker not always present, but you do a lumbar puncture, we can find the alpha-synuclein. So let's see in what condition you find alpha-synuclein in the lumbar puncture, the CSF versus the skin or in different other places. So you see in Parkinson's or Parkinson's associated diseases, so we see sporadic Parkinson's, usually the alpha-synuclein is positive in the CSF and the skin. So you have Parkinson, definitely totally the one that is 85%, the real Parkinson's, the biomarker is present in skin and CSF. And genetic Parkinson's disease, it will be a little different. So you have CSF, but you get into the skin biopsy, then it could be negative. See, so you say, okay, that's different between, and that's the genotype and the phenotype. So the sporadic, 85%, CSF and skin, but just in the genetic, not always the alpha-synuclein skin biopsy will be positive. So that's an issue. We're trying to get the biopsy getting better. We just in the beginning to get all this treatment or get a biopsy, but that's what the study shows. You get genetic Parkinson's disease is different. You have mutation versus is in some genes is different, but again, it's only present in the CSF, the alpha-synuclein. So you have some incidental or preclinical, subclinical, or premotor symptoms of Parkinson's. Sometimes you don't even find, it's plus minus. You can find it or not, the alpha-synuclein in CSF. Why? Because it's in the beginning. So the marker is not that strong. What happened with Lewy body dementia? And the Lewy body dementia or sporadic Lewy body dementia, you find the alpha-synuclein is present in CSF and as well as present in the skin. So you think about it, we're talking the alpha-synuclein is in the whole brain. So probably all of this marker is going to go to the CSF or the cerebrospinal fluid is around the brain. In early body dementia, you see there is some, depends on the situation. It could be present or not present, not conclusive. And Lewy body dementia with dysphagia, difficulty swallowing, you don't find it. So there is not only one. With this, we're going to, there is not only one condition. They make it more difficult. So that means we cannot rely only one test. You get one test and say, no, you don't have it, but then the future will tell it where the phenotype. So again, that's the issue with the gene. You say, no, you the gene or you have the risk, but then you don't have it, or you have the risk, or you carry the gene, but it's different how that gene is expressed in yourself, what symptoms you have or not. Okay, so you see there's some different. Now let's go from MSA, multisystem atrophy. So multisystem atrophy, that means multiple systems being affected. And sometimes we have the clinical suspicion. But now we have sub, especially like some people need to go to Gainesville and get more specific for that testing. My clinical impression, if you tell me you have orthostatic hypotension, and I see you don't get better with medication, and then see you have constipation and assisting the cardiovascular orthostatic hypotension, increase of sweating, and say, oh, okay, probably have multisystem atrophy. But you came to me, no, my only issue is my balance. I don't have problem with orthostatic hypotension. No, I don't have problem with decrease of sweating. My only issue is the balance. So, okay, I have to think twice to see really this is multisystem atrophy or just dealing with cerebellar condition. Yeah, it could be that it just a cerebellar ataxia. Okay, there is another condition. It's called, listen to this word. I promise this is not a bad word. Olivopontocerebellar atrophy. So this is multisystem atrophy C. And there is another condition, is dentro-rural paludism atrophy. Dupla, again, that's another condition affecting all the density in the cerebellum, the length in the brainstem, and atrophy in the brain. So you see how looking for that particular MSA type P, the CSF and the skin will be positive. In the olivopontocerebellar atrophy or MSA type C, the CSF and the skin is positive. So if you go to one of these conditions that we are not clear diagnosis, if the skin is negative, then we have to look the CSF is positive, and then we have a biomarker. Okay, so how the alpha-synuclein can distribute in different areas of the brain. So there is as well, again, some confounders. You can get alpha-synuclein as well. Some people having as well Alzheimer's or vice versa. Then we have to look for some mutations. So these are our cases. Again, this is not as simple. Just go straight to one pathology. Okay. So take a deep breath and let's turn the page to a different thing. So we have been found some people send it for deep brain stimulation, and then there is another option, this the high frequency ultrasound. So I have to look what the journal had to say about this. The reason why I'm a movement disorder specialist is because deep brain stimulation. When I was in my second year at Georgetown, I'm very, very happy to be Washington, D.C. I don't miss the snow, but I miss the Cherry Blossom Festival. I miss the zoo. I don't miss the subway. I miss it because I was sleeping a lot in the subway, and that's after cold. But when I was in my second year, I have one patient that, again, in Parkinson's and neurology, you say, oh, I'm sorry, you have Parkinson's, we can do, you have a tremor, nothing is working, I'm sorry. But one thing that wakes me up from this is somebody was in the ICU, have the brain stimulation implanted, they turn on, from tremor like that, stop it right away. And it's magic. I see people crying for happiness because they say, oh, this and that happens. So most of the time happens. There could be complications, yes, but some people cannot get the brain stimulation because the aging or because complications going to neurosurgery. So another procedure is the high frequency ultrasound. So what the high frequency ultrasound? So we don't have here in town, but have been in Celebration in Florida for a very long time. In Tampa, we have a center for a high-frequency ultrasound. In Miami, in Boca Raton. So basically, the first thing you need to be aware of, you go to this procedure, is you have to lose your hair. They had to shave your head. They place a frame, and then the surgeon with MRI will guide an ultrasound towards the area that produces the tremor, usually the BIM, which is the ventral intermedius nucleus of the thalamus. And it's not like you go in and out. No, it's not just 10 seconds, boom, and that's it. No, it's not like that. You go there, you make a sentence on looking at that, and then you say, okay, go back until we get it right. I say the high frequency ultrasound is like, again, I give an example like in war. So you are Ukraine, Russia, if there is the target with a drone, get to one base in Russia, vice versa. You get it right, good. You kill the militaries or you're supposed to kill. But you're off, you kill civilians, right? The same with the brain. This is an ablation. So this is not like a benign, it's a high frequency. High frequency can produce a small micro lesion in your brain. In a good target, fine, then the tremor will be good. But it's a little off, you can have like a stroke. But let's see what they say here about the studies, because that changed a little bit. We don't have this here in town, but again, in Tampa General, we have celebration have for longer time, and I have referred many people with that. Usually they came first in Europe. Many things come in Europe, and now we have here for a long time. So let's see what they said here in this article about this. Then that way it's not only biased because we don't have too many experience about this. So they said unilateral subthalamic nucleus, we're looking at about the STN, the subthalamic nucleus, the same target that we use for DBS for the most part. Ablation, remember ablation, we're talking with killing cells with guided by MRI. With the ultrasound, remember we can do low frequency versus high frequency. We want to see in another article I just mentioned to you about focal hand dystonia. We can use low frequency magnetic stimulation for people with dystonia that can happen in Parkinson's as well, or just people who play the guitar or playing the piano. So the high frequency is going to produce more, going to produce damage or produce ablation, and that's what we use. Ultrasound as well has been used in neurology or medicine to make the blood barrier a little more open to medication. Is low frequency. Low frequency, again, we are using it well for dystonias. But for this condition, it's high frequency. So basically, is something is irreversible. So we kill those cells, and killing those cells that produce the problem, you get better. So this is used in asymmetric Parkinson's disease. Most of these conditions, again, we have a big question. Deep brain stimulation is only for people for real Parkinson's. That will not work for Parkinsonism. With the high frequency ultrasound, I was told by the technician, and as well looking in the articles, that works well for Parkinsonism. They claim that yes, but I had to research a little more. So what happened with the asymmetry? We talk about the real Parkinson's. So in this study, what they're trying to see how good, how effective was the streaming for people with Parkinson's disease, and if there's any side effects or what happened after having these procedures. So what happened? There was a prospective study. There was on one center, and they get patients with Parkinson's. They have 6 people with Parkinson's disease, and they target the STN, subthalamic nucleus. So what was the primary comp? So we look at the study, see what you're looking for. So the outcome, what we're looking is how you get improvement with the test we do this, the Unified Parkinson's Disease Rating Scale Type 3. Remember, I always tell you when you come to my clinic, the higher the number, the worse. So remember, if we get a score like 20, you go to 5, that's an excellent thing. So that's looking for the UPRS 3. And as well looking if you need to decrease the amount of medication you're taking, or looking for adverse reactions. So we have the follow-up, and then let's see what happened with these patients. So what were the results? So basically looking for the UPRS, they're looking definitely was a significant improvement in the scores, not only for tremors, because we're thinking only for tremors, but it's not only tremors. So that's the surprise, and that's when learning this again. Again, I don't have too much experience with this technique. I was thinking it's only for tremors, but it's not. They said, and they claimed that was improvement in rigidity and bradykinesia, or brady, slow kinesis movement. So improvement the bradykinesia. I always, when you get better with the bradykinesia, I said, you are like my Mexican cousin, like a Speedy Gonzalez. Now you're fast, right? So the bradykinesia, you got better. As well, the tremor. So it's not only the tremor, but they get the three. So that's surprising for me, and I'm glad that helps. And again, the same with deep brain stimulation. Most of the neurosurgeons said, no, the deep brain stimulation will help you only for the tremors. And I think that the ultrasound and as well, the brain stimulation helps with rigidity and bradykinesia. So they compare with the baseline, the controls, and definitely improve. So far with the result, they tell me that's good. And let's go for the conclusion. I just how in all these side place, they say we are close to the beach. Unfortunately, we were here, but hopefully we are living in this beautiful place. So this is what that we get the good news to our beach here to get a new knowledge about what's there. So in the conclusion, the unilateral high frequency ultrasound targeting the STN, actually resulting with significant motor improvement. And again, not only for tremor, but bradykinesia and for the stiffness or rigidity. So I'm very excited about this, and hopefully the results of most likely centers that do this say the same thing. But this is the article again, what I trust, and is the International Movement Disorder Society Journal. Okay, so let's turn the page. Everybody awake? Everybody good? Yeah? Okay, good. Okay, so now in these journals clubs, I want to I'll talk about our movement disorder, because Parkinson's is the most important thing, but or the most frequent one, but we have another movement disorder. So I want to start talking about another movement disorders, because this is only Parkinson's place, and we include another movement disorders. So there is a condition which is very common in people that play the guitar, or people that write a lot, or play the piano. Like there is a common thing that people playing pianists or people that play the guitar, they get trying to get the guitar and get cramps and not able to do it. Or people that write a lot is trying to write and get stuck, that we call focal hand dystonia. Or gradis cramp, people try to write. So talking about, going to the previous, about the low frequency ultrasound. So it's in getting low frequency repetitive sensory stimulation probably can improve the outcome. So let's see what happened with this condition here. So let's talk about dystonia. So dystonia, in that particular, we talk about hand, but Parkinson's people, patient can have as well dystonia. What is dystonia? So tonia just means the tone of the muscle is how, if I touch my muscle here, how contracted it is. Right now, it's not too flaccid, it's not contracted because it's in rest. But people with Parkinson can get stiff, or people can have dystonia, meaning the muscle is too stiff and could be painful. Many of you suffer from dystonia sometimes with the medication is wearing off and getting crawling of the toes or something, and that contraction like that is what we call dystonia. And usually pursue with abnormal posture. Could be dystonia of the neck, okay, dystonia of the hand or the toes. But in this particular, we're talking another condition is called focal hand dystonia. So they are found that really with this stimulation with low frequency, people get better, but go with the high frequency is the opposite. So I'm going to tell you about dystonia presents, and I have been very prevalent. Sometimes the standard of care for this condition is doing Botox injections. But with people can have general, this is focal. People have general dystonia, people are very rigid. Deep brain stimulation have been working for that. But learning for this particular, this is focal, we do the stimulation in the arm. And it seems this is very promising. So hopefully we can get to another treatment with this. So basically this study got to get a specific stimulation for those muscles that produce the dystonia. This is the way they do it. So basically they're doing the stimulation to the area that produce the dystonia. And let's go for the results. So basically there is something that's called synchronous, that means go and the same way, or asynchronous frequency, so somatosensory stimulation. Improve that. We try to change the pattern in the brain. What happens with people have dystonia because they're doing too much of these movements? There is something we call the motor planning in the brain. So because they are doing all the stuff, for some reason that area of the brain, I don't know, get tired or something, but they model, so they get the moment they say, no, I don't want to do it anymore. So try to do this stimulation that kind to change these models, and then hopefully it's in the results are very good. So usually when it's low frequency is good, but the opposite happening with high frequency. Interesting. So this is the conclusion. Our findings confirm that the presence of abnormal homeostatic plasticity. So the plasticity, that means what happened in the brain and how it's going to control the hand. When doing sensory system with dystonia, we can produce some changes in that. What can stimulate, what can inhibit those circuits and make the change in the dystonia. So this is something we are very happy about this. Okay. We changed the page. Let's see where we're at the time. I have many articles for you. We have 1 minute. So let me actually get it late so I give you more. So let's talk a little bit about deep brain stimulation and programming. Remember, we talked about artificial intelligence, and then in the beginning, we spent hours, the whole morning. We say, a new patient with DBS. This patient want to tell me the whole morning. But now, the part is that we have the computer do it by itself, and then now the beginning deep brain stimulation is only go to place information to the battery and then do the thing. But now we have a feedback from the DBS. And now we actually have the brain sense. So they will look some activities in the brain and say, okay, you have the activity better, you good. But now the computers and the future is that the system by itself will say, okay, where is it? Let's see what the neurosurgeon plays the thing, and the computer or the system will read and say, okay, this is your best program, and bam. It depends what you do. You're doing golfing, you needed this program for golfing, they do adjustment. It's like you're driving your automatic car. Yes, you get the car that you can drive by itself. You get it there, and you're sleeping. They say, no, just shoot it down. It's like you, and in the light, and the traffic light say, no, you're not doing anything. Just the stop. So that's the future. So we're looking at the deep brain stimulation. Can look for, first of all, it's very important for the placement. So we relate, very important, we need to have a good neurosurgeon. They have to implant the electrodes, and there is a good place that will work. So in the first visit, when turning on, we know it's going to work. We turn on the DVS, it not work, it's misplaced, it's no matter what I do, it's not there. So now we have some different software. So the software is going to tell the different programs for the particular patient. And as the patient start using the DBS, the software will change and want to do the change in the stimulation. So it's something about, and hide this with me, connectomic, the same thing with about dermatomes, now the connections, connectomes. Okay, we're getting more specific with the pathways of the brain. So we're getting a mapping of the connections of the brain. So something like this. Let me see here. Let me see. I can, no, not yet. There is a pathways that the neuroimaging is looking for all the tracks, and actually they can see in different colors. So basically, the future for deep brain stimulation is we're here, the neurosurgeon go there, and then I start the turning on, and the programming will say, okay, let's go, and bam, this is the program you needed. So I don't want to tell you more, so thank you very much. I got it in time, even I got 2 minutes late, no, 5, but I got it 3 minutes. Questions or any questions? No, people want to leave. Okay. My pleasure. Thank you for coming. Yes. Very good. So that's a very question. So I want to repeat for the people in the that is in the in internet. So basically, what the difference between DVS? DVS stands for deep brain stimulation, and TMS stands for transmagnetic stimulation. So DVS is actually neurosurgery. So you implant electrodes, and it's deep in the brain. Electrode doing stimulation that come from like a pacemaker from here. So that's deep brain stimulation. TMS is transmagnetic stimulation. So basically, it's a stimulation towards the brain. So to a magnet to get waves to stimulate the brain. So that's different. And the people getting depression, getting one of the treatments TMS. Go to the session, they give the stimulation to that. Some people got headaches, some people got better. But now DVS, we have been used as well for depression. And now for epilepsy, and now as well, hopefully for memory. So we'll see. That's the difference. So one is surgery, the other is a magnet producing a stimulation to the brain. Any other questions? Yes. Transmagnetic stimulation. It's not invasive in quotation, right? Is they saying that they said, no, the ultrasound is not invasive, but it is actually. So we're talking deep brain stimulation, TMS, and high frequency ultrasound. So ultrasound, we do low frequency for diagnosis. So it's a girl, they do an ultrasound. That is harmless because it's very low frequency. But you go to a high frequency, you can produce the damage. And now the TMS is just a magnet producing go to the cranium, trans that, and do some stimulation to take it from that depression and change the chemicals in the brain. For the TMS, I don't know many places that doing. I hear from some patients that doing it. High frequency ultrasound we don't have here, and DBS in Tampa, and the brain stimulation we here with Dr. Vives. Transmagnetic stimulation. I think there's some people. I think go as well to Tampa or other places. I don't know. There is some places here. Yeah, so the question is the treatment for focal dystonia with the stimulation that, so this is something in research. So basically, it's try to get the stimulation with some stimulation here to try to change the pattern here in your brain. So basically, again, what happened with focal dystonia or radius cramp, like people getting like this, very repetitive. So the brain said, oh, okay, again, 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 again. And at some point said, the model said, no, get stuck. I don't know. And then trying to get the stimulation here with a low frequency, change that pattern, and then get a little confusion. Okay, let's do it. It's okay. Like relax the system. Which one? That's just it. So the question for the people doing in the computer, basically they are asking this reversible. That is just a stimulation. So it's like you're getting like electric shock when you have an EMG, just an stimulation right there. So it's not just a stimulation, it's nothing. The transcranial magnetic stimulation, people complain of headaches. I don't know if the waves, the intensity can get headaches, but that's again is not supposed not invasive, it's just a stimulation. Yes, sir. Yes, so the question is about the artificial intelligence. I'm sorry, we use a lot of acronyms, so I want to be sure you understand that. When I started my PG1 coming from Colombia, having a good English was even worse than now. I started my first year and I said, this is a 78 white slash O, WM, white male, RH, right-handed, with HX history of CHF, congestive failure, with CC, she complained, of dysphasia. Okay, dysphasia, I understand. So AA, again, Houston, we a problem. Artificial intelligence is have been applying for many fields in medicine. So like that, you know, even though for artificial intelligence as well, you see many people coming to the office already with genetic testing about saying, I can take ibuprofen, but I can take Tylenol, but I can take this and that. So yes. So there's a lot of applications. So this is going to take a lot of fields, not only medicine, but many things. You know, artificial intelligence have been used for many, they have many applications. Thank you. So he is very kind to, and that's what this is about. You will never have an experience I'll share it with everybody. So this is very important. It's different when a patient tells us when a doctor says so. It's true. So the same that happened with the correction can happen with right artery. For the most part, in the right artery classified, like 75 people with right artery do very well. But in 25%, probably doesn't work. Or you can have, I have one patient who have allergy to Crexont, one person. And it's also that doesn't fit you. It's like you want for shoes, you say, no, I prefer my old shoes. But this in technology have been proven, and I was hoping you said 1 week I have, and finally it works. But no, didn't work. Or it's possible you didn't try enough. But it's possible you already have significant side effect. It's not good. It's not really good to try it again because you got more side effects. But for some, if somebody want to speak out from the audience that have been taking Kirkson, you got to share your opposite experience, I'll be happy to hear. Anyone want to share? Please, thank you. I don't want to point you to you, but I know, but thank you. I'm Dr. Gonzalez, and I approve this message.
Oh, sure. Thank you. Thank you. The second day that my husband took Crexon, he was out vacuuming and cleaning his car and doing all these things that he used to love to do, that he hadn't done for several years. So the tremors are better, and the what you call it, the extended release
The on
make,
time.
yes, makes it so much more user friendly to figure out when to eat, when to not for the
Sorry to
midday.
interrupt you. Right, that is one of the main things.
Right.
The compliance, usually with a regular carbiopa or even Rytary, you have to take up to 3 times daily. With you taking carbiopa leopa less than 500 milligrams, you can take it only twice a day. 280 milligrams of correction, you take it in the morning and night, and you do it. You're okay. Now you don't have any issue with the protein. You want to have a very nice steak at night, at noon. Don't worry about it. And it's only twice a day. It's compliance is beautiful. It's easier. So I say, and sorry, keep going. I don't want to interrupt you. You finish with the, no, you can, we need to get this. So again, the correction on a medication is like you go to a party. Depending how you go in the party, you talk about how the party was. It's probably many people have fun, but a couple of people doing well. It's possible they have the alcohol, you feeling bad, and you get it worse, and that's supposed to be that you have the opposite reaction. So that with the correction. I just have somebody, I just want, of course, I know the name, but somebody have a very difficult to treat with Parkinson's many years. And the brother was insisting, and the brother, no, I want to give more. And so it was like nightmare for me and for the brother and the patient in the middle. I tried to get the right medication, giving this, giving more Embrilla. Let's try carbiopa. He was overdosed, amantadine, and hallucinations. And boom, correction came. And I told my, and the telemedicine and back and forth. We had like 10 sessions, and finally, I asked my nurse practitioner and tell him, okay, finally we have this, the correction. Give the correction to him. He came today, different person. The first time I have the smile again. The patient is taking only twice a day. And again, it's a different person. Before he was saying a couple of words today he was asking me questions, he was smiling. The brother was okay with me. Brother was very upset with me because nothing was working. So finally, I said, okay. Thank you, Gregson. So it's beautiful. Again, the same thing happened with Rytary. I encourage people being in correct zone, first of all, to wait for a week. That is very similar that with people taking antidepressants. You have antidepressant, you have to wait 2 weeks. 2 weeks could be hell because you actually, when you have depression, the antidepressant can make you feel bad. After 2 weeks or 3 weeks, people feel better. With Crexon, all I ask is 1 week. But you have a very side effect like you have from the beginning. Of course, you don't want to take it, right? So, but for the most part, I'm very happy and welcome Crexon. And again, so far, I've seen that have been approved. I'm very surprised that insurance is approving it. I'm very surprised. I don't know, again, if somebody else want to share what I had to pay for that, but I had somebody, actually, the person this morning said they pay nothing. Why? Because the insurance approved it. After fighting, there's a fight, paperwork, but I very surprised that now is less fight with than the Rytary. The difference as well with Rytary Crexon is that in the past I had to give a lot of samples of Rytary. With Crexon, just a couple samples, works nicely. I send a prescription, and so far I have only one denied. So far only one people having side effects. Anybody else that want to share your experience? So the comparison, and again, is the same manufacturer. So the same people that do the Rytary. So the difference is that it gives at least 1.5 hours or more on time. So you take it twice a day, we're talking 3 hours. So stay in your system more. The difference is how the technology may attach this. There is a polymer that attach to your stomach, and they make like a slow release, really a slow release. And the difference as well, they get the improvement because they do immediate release and extended release. So in the beginning, the immediate release kick out, and then this low release is stays sticking your stomach and goes slowly better. I'm saying that's the difference. And it could be the difference with the price. Yes. You have a Susan. Now, not only have a patient, but have a doctor. So this is a very valuable. So please talk to me, doctor. Thank you. No, no, I asked the people to pay attention to you. That's what it's meant. So probably need make some adjustment. For the most part, again, and that's the beauty of this. So usually you taking more than less than 400 milligrams of carbidopa we use only twice a day. Usually the regular dose, and this is better dose for me. Rytary, for me from the beginning was a nightmare to prescribe. Initially, I had a small thing like people remember back in the day when they want to be pregnant and said, this is your date. So look at that and find this is your date. The same with Rytary. Initially, how much you taking? Look at that, how to do this, how to the tables, and it was a nightmare. And initially, I was thinking we were overdosing people with carbidopa. But now with this correction, it's simple. So you get, okay, how much you taking? 500 or more than 500? Okay, I taking less than 500. Fine. What is the percentage you taking? You taking the 100s? Good. So on the table is 100. So bam, they give me the formulation of 280 twice a day. Now, you taking more than 500, then most likely you have to take at least 3 times daily. And even though if looking at you taking twice a day, it is not working, then we have to try it 3 times daily. And probably not the 280, but we can try the 3. It's too much, you can regulate the thing. So that's the beauty. And you and Rytary is a different story. So you and Rytary, milligram per milligram is equivalent. So you just say you 1,500 of Rytary, have to give 1,500 of Crexon, and I just look for the presentation is 280, so I divide 1,500 divided into 80, so I know how many capsules I have to take per day. So that's the easy thing. I'm very happy Crexon here, lost headaches easier. And the beauty again, I don't know, you guys have any issue filling the medication? You want to share what's the process to get that? There was any problem? Sure. So we, unfortunately, usually an example of this is for headaches. For headaches, we have new medications and they're very good. But now we have just one nurse for prioritization. So the headache goes from the patient to me. Because now, I know, I already know in my mind. I prescribe this medication. I know the insurance said no. Then after I said no, we appeal. Now the appeal, finally, after going back and forth, I have one patient is that like that for 2 months. And then we try everything. I said in my note, the only medication is Bravely, but even though they said denied, and now I have to write another letter of necessity. So that's a problem in paperwork. But I found, I don't know, that's the only case, but I found, I don't know, in other cases that is less the paperwork. And so far, I have probably one person write down, but for the most part, it's approved. I don't know. You want to share your experience? So that's a good question. So the question is if there's an effect on the blood pressure. So again, it's the carbidopa, but it's because it's very low, really extended release. There is no this peak that you have with the immediate release. The problem with the blood pressure is, and I was hoping and trying with some people having orthostatic hypotension, and unfortunately with the person I tried again, she had the same reaction that was not able to tolerate it. But because there is no peak, it's supposed to be less effective than blood pressure. That's in theory. Again, it's new for me so far. It's actually much better, less side effects, compliance is better. The issue will be the price or if they have significant side effects. So far, one problem with allergy and one didn't work. Again, I place an example right there. I don't know with this one, I place the same example. It's like you place a turtle, but this turtle actually have something that speed up in a hard way. Yeah, it's very slow, and then people start. So it is too slow. It's not going to work if somebody have already a slow bowel. So you have somebody with gastroparesis or very significant constipation, probably it's not going to work. But if the medication work very well, and now they have something immediate release to kick in, and then the extended release, they suppose not, because the part of the immediate release is just a small amount. The other carbidopa with immediate release, very peak, and that peak is when the blood pressure goes down, and then dropping, and it will be a problem. Any other question? I'm very pleased. This has been very good. Even you are awake. Look at this. I appreciate it. I appreciate it very much. Okay, so I think for Susan, we continue with this. I will continue reviewing articles. I found that. And for the most part, I'm looking a lot about Parkinson's, but I want to start including some other movement disorders and small articles. In that way, we learn about other movement disorders. Okay. Okay, thank you everybody for coming. Happy New Year.